Our next speaker is Dr. Mona Saraiya. Dr. Saraiya joined the Centers for Disease Control and Prevention as an Epidemic Intelligence Service Officer in the Division of Reproductive Health and has ascended the ranks, literally and figuratively, to the Associate Director of the Office of International Cancer Control in the Division of Cancer Prevention. Much of her career at CDC has been spent focusing on skin cancer epidemiology, cervical cancer screening, and human papillomavirus research. Dr. Saraiya.
Thank you for the honor for speaking today, and I'm going to speak a little bit about the perspective from CDC on the challenges and opportunities in working in low resource settings. If I can get the slides on. So for global chronic diseases at CDC, our mission is to advance coordinated global approach for NCD prevention. So cancer is part of that picture by leveraging existing resources that the CDC has invested in and programs as well as partnerships to build capacity and increase impact. This is a picture of the CDC org chart. And what I wanted to highlight to you is that where global health works for chronic diseases is across two major groups. The Center for Global Health on the left, formerly led by Tom Kenyon, currently vacant, and then the office, the Chronic Disease Center, where we have several divisions, including the Cancer Division. And this is going to come back in terms of when we talk about political barriers as well. This is our division, our Chronic Disease Center, and we have diabetes, heart disease, as well as cancer. You may or may not be aware that the CDC funds a variety of programs domestically, and that's traditionally for the cancer group our mandate. We have the National Breast and Cervical Cancer Early Detection Program, really focusing on low-income, underserved populations, but now is in all 50 states. We have a comprehensive cancer control program because the U.S. has not one cancer control plan, but every state has a cancer control plan, as well as the National Program of Cancer Registries, which now, in combination with the SEER, has 100% coverage, and then the Colorectal Cancer Control Program, which is trying to bring more organizational structure to cancer screening in general. What this slide I wanted to highlight is that we're not talking about just states, but territories and tribes, and that's going to be an important issue when we think about the problems that, that we face that just in our backyard, the U.S. Pacific Islands or the U.S.-Mexico border, are examples of where similar kind of approaches have to be worked on for global health. The breast and cervical cancer screening program has provided more than 12 million screening exams, and as I mentioned, our approach now is to have a more population-based approach domestically. We have a program. We would say that besides managed care organizations, we are probably one of the few organized screening programs in the United States, and we have a significant effort that we've promoted for quality. Colorectal cancer screening, we're trying to focus on health system change to improve colorectal cancer screening and, of course, provide direct funds for direct screening. The comprehensive cancer control, there is a focus on policy and systems and environmental changes, and this year particularly, the last few years, we've been focusing on increased HPV vaccination coverage in partnership with the immunization groups in each of the states. These are just some of our priorities. And one thing that I wanted to highlight was promoting health equity as it relates to cancer control. And the cancer registries, as I mentioned, we are one of the few countries globally that has 100% population coverage. And the other thing that I wanted to highlight is that we have an approach of economics research on cancer. In almost every one of our programs, we use health economics to inform cancer control plannings for each of the programs, whether it's breast and cervical, the cancer registries, or colorectal cancer. And this is going to be really important when we think about the lessons learned from domestic to global. So the things that I want to touch on today are challenges and opportunities for cancer control. The themes that may not be touched in other talks would be surveillance. We have very limited systems globally for cancer and other non-communicable diseases. And if we don't invest in those systems immediately, we're not going to really know the burden of this problem. primary prevention. There needs to be more emphasis on strategies, that, as Dr. Stevens has alluded to, on those that have a larger attributable fraction. Early detection and screening, there's a real distinction between those two. There's very limited evidence in certain approaches, and why are we promoting them? Because they worked in the US? There tends to be a very much approach about early detection, cancer screening that is a little concerning, and we're not thinking about over-screening when we think about promoting these approaches globally. My thing is an organized approach. Even in the United States, we don't have an organized approach, and I'll allude to this in Europe. How can we think about investing in screening from an organized perspective? If we don't have the linkages to treatment, we should really think about it twice before we invest in screening and treatment. As I mentioned, behavioral and economic disciplines are really undervalued globally, and I think that there could be a significant investments there, because in behavioral approaches, for example, if you are not educating the public about HPV vaccination or screening, it can often come back to bite you. When we think about emerging technologies, we always think about them in isolation in terms of what the clinical individual approach will be, and I'd like to think about it from a more population-based approach, and I'm going to touch a little bit on capacity and politics. So the opportunities for the future, these are some of the opportunities that I already mentioned, but this is the same slide that my division director used for our domestic work, and I think that a lot of these opportunities can be applied for global. These are looking at patient-centered communication, thinking about the complexity of screening modalities, the aging population, focusing a little bit more on cancer survivors and the multiple chronic conditions, as well as the importance of the primary prevention activities such as obesity, tobacco cessation, as well as vaccines. So many of you are familiar, and I hope I'm not preaching to the choir, about the high-level meeting in 2011. It was the second time that the U.S. General Assembly meeting called for working on a disease-specific entity. And it focused on 4 modifiable risk factors as well as 4 chronic diseases. And this is the first time there was a political declaration adopted to strengthen systems, work with the whole of society approach, reduce risk factors, et cetera. There were a set of 9 voluntary global targets for non-communicable diseases to be reached by 2025. The one on the top is the premature mortality from both chronic disease reduction, including cancer, by 25% by 2025. But in addition to that, there were a set of additional 25 indicators, and I wanted to highlight these ones highlighted relate directly to cancer control, including cancer incidence by type of cancer, reducing the risk factors such as alcohol, tobacco, overweight, and obesity, as well as a system response that focuses on cervical cancer screening, vaccination, as well as access to palliative care. Here is the status of vital registration, mortality, or cancer incidence registration from the Cancer Atlas in 2015. So what I wanted to highlight here is look at the focus here on vital registration or cancer registration. Very low in sub-Saharan Africa. Even in Latin America, it's surprising that only 8% of the population is covered by cancer registration and only 25% by vital stats. So what can we do to focus on this particular area? There is the IARC initiative called the Global Initiative for Cancer Registry that I wanted to touch a little bit on, where they're trying to actually create centers for excellence throughout the world and increase support for countries to start a cancer registry, to maintain a cancer registries, and actually to analyze and disseminate their data. One of the things is that there's not enough of an investment in cancer surveillance. Many of the countries want 100% population coverage, which may not be realistic. While it may be true in the US, there may be important to focus on particular sentinel sites where there can be high quality data associated with their interventions. But a lot of countries have asked us, how much does it cost to start a cancer registry, add more cancer registries? And this is where some of the approaches that we've used domestically have been adapted globally. So there has been a U.S. economic analysis of how much it costs to run a cancer registry, and it's been roughly around $60 to $250 per case, depending on where the cancer registry is and in what state. So what we've done is try to standardize this costing tool across various countries and pilot it. And so we're hoping that this will be important for people to know, to advocate for more funds and estimate the resources, because knowing what your resources go to can also help you with efficiencies in expanding or maintaining the cancer registry. So this is where we're investing a series of pilot studies in Kenya, India, Colombia, Uganda, and Barbados. And then what I wanted to highlight to you is that these are countries that have various different scenarios. Some have rural cancer registries, which is going to be probably more expensive to run and maintain, but also very important. Some are just starting new cancer registries. And then I'm going to hit a little bit interesting facts about Barbados as well. So we have done various pilots over the last 3 years. And our economist has visited collaborative registries in each of these countries, provided training, trying to systemize the way that the data is collected, and the data is reported back to the ministries of health. These are some preliminary, hot-off-the-press results that show that a lot of the cancer registries are funded by their host institutions, whether it's a university or Ministry of Health, and it really varies by country. So here in Gulu, Uganda, for example, almost 100% of the cost of running a cancer registries is funded by the Ministry of Health and the university. And this varies, as you see in Barbados, only 40% of the cost of running a cancer registries is borne by the host institution. So this will be important when we think about future support. Most of the funds that go to running a cancer registry are basically related to labor, data collection, as you can see in the green bar. And this will be important as you think about efficiencies in the future. Let's say there's electronic data reporting. You will see a significant efficiency in the future. So having this information will be important. What about cancer registries being part of the NCD surveillance system? Can we think about efficiencies? I wanted to highlight the Barbados National Cancer Registry. This is operated by the Chronic Disease Research Center on behalf of the Barbados Ministry of Health. They have both a stroke, heart, and cancer registry. And actually, it was the cancer registry that came after the heels of having a stroke and MI registry. As part of the costing assessment, we were able to assess various fixed and variable costs related to having these functions. And I think one of the things I wanted to highlight is that in a Caribbean or even the Pacific Islands, the geographical variability will result in an increased cost per case. But the other point that we wanted to highlight here was that the costs are significantly decreased because of the shared infrastructure that Barbados is having with shared buildings, shared personnel that are registering a case of stroke, case of MI, as well as a case of cancer. Cancer screening. So we heard a little bit about the goal of cancer screening programs and how they're a little bit different from cancer screening versus early detection. And what I wanted to highlight is that I have sensed in my last 5 years is there's sort of a missing picture about an organized approach to screening. Often what is introduced is just the screening test and the clinical scenario, but the population-based approach is really missing. And we know about early diagnosis, and that may have a value, especially for breast cancer. So the best buys for cancer screening, these were already highlighted. I just wanted to highlight that we also need to think about those cancers that are probably not supported in high-income countries, but they have a significant burden in low-income countries, and what can we do to promote it in an evidence-based manner. And these include, like, for example, prostate cancer as well as lung cancer screening. There is a tendency for us to take the emerging technology in high-income countries and immediately adopt it, but that's not always the case. Cervical is definitely one of the best buys, and I wanted to highlight a little bit about colorectal in the future as well. These are just fundamental elements of a cancer screening program. Even in the U.S., we would benefit from following all of these particular tenets of organized screening, such as having a centralized screening registry, linking registries to diagnostic tests for recall, tracking and screening positive, as well as quality assurance issues. So these are just a list of a variety of activities. One of the things that organized screening programs need to have is to have a public policy documented in a law, policy that looks at who's eligible, what is the protocol, how often one screens. It should be financed by public sources, ideally, and also look at making sure that quality assurance and control are assured at a national level. These are just some tenets that IARC has in terms of organized screening programs. And one of the things I wanted to highlight is a substantial IT infrastructure is required to support programs, and this is often not considered. Some of the words of wisdom from many of the European programs that have had organized screening is that it takes 10 years for planning, pilot, and implementing a cancer screening program. Start small, scale up regularly, and as you would expect, universal coverage for dedication for clinical preventive services makes a huge impact. This is a paper by Elfstrom et al. That looks at the European organized screening programs. And what I wanted to highlight here is that the coverage is quite low in select countries, especially in Eastern European countries. So when we think about Europe as our model, we also need to think about which country, because not all countries are equal in Europe. But you can see in Poland, the coverage is 25%, Romania, 20%. So there is significant amount of investments. The Eastern Europe is actually very similar to some of the low and middle income countries. This, one of the highlights of an organized screening program is to do consistent audits in your program. As you can see here, there's very few countries, even in Europe, that consistently do audits on a regular basis to see why they're having the case of cervical cancer. This is an interesting paper. I will provide the reference later on the overview of colorectal cancer screening programs. But again, the same kind of message here. And I think colorectal, there's probably a real opportunity to make an impact because, in my opinion, cervical and breast cancer are already out of the barn. And colorectal cancer, you may be able to, before it's introduced in low and middle income settings, there's an opportunity to sort of make an impact because there's a lot of information about organized screening programs. So what I wanted to highlight here is that very few most of the colorectal cancer screening programs are opportunistic and not organized. Some of the lessons learned by this author were that in Europe, most of the organized screening programs use non-invasive colorectal cancer screening tests. So something for all of us to think about as we in the United States have a lot of focus on colonoscopies. Many Eastern European countries have no organized screening, and even some of these countries that have organized screening, like France, have very poor coverage rates. Wanted to highlight the role of frontline providers and how we can learn from countries like Thailand and others and their investment in community healthcare workers, as well as nurses and non-physician providers. I am not going to touch too much on HPV vaccination because I know we have Dr. Kathleen as well as Doyen that are going to be speaking about vaccine, but what are some lessons learned for vaccine? We have low coverage in the United States, high coverage in Australia. Australia is actually able to show an impact on pre-invasive cervical cancers and are seriously considering revisiting their screening strategy to once or twice in a lifetime. So that investment in vaccination is really key, and I don't feel like many low and middle income countries have embraced it as much as they could, especially at the cost of screening. Gavi eligible countries are most likely to benefit from vaccination, but it's those middle income countries that actually have to pay for the vaccine themselves that I think are in the most serious phase. They're only in pilot phase, not able to scale up as much. So one of the things I'd like to raise here was the investment in infrastructure of actually screening more than once in a lifetime for a woman versus vaccination, and whether some countries really need to revisit that issue. One program that we're working on in Thailand is a country that has universal coverage, introduces PAP-based screening as well as VIA-based screening, and they wanted to introduce HPV testing. So they have systematically introduced it in one province and are evaluating it. And this is one of those examples where CDC has provided some technical assistance and what they're trying to focus on is improving their follow-up. The U.S. Pacific Islands, I understand Dr. Neil Palafax will be speaking later, but one of the issues for the U.S. Pacific Islands is that it's supported by 3 U.S. programs. And I don't think that those 3 U.S. programs could convene or talk to each other as much as they are. There's 3 separate systems where cervical cancer screening is provided support: family planning, the CDC breast and cervical cancer program, as well as HRSA. Despite all that effort and investment, the coverage still remains between 30 to 55%, and it has a pretty high burden of cervical cancer. So what we're trying to do is have these programs speak to each other, think about introducing a demonstration project. And one of the things that we were limited by is that we had to use U.S. guidelines for the U.S. Pacific Islands. So we tried to get around this by having the American College of OBGYN speak about why it's important to use low technologies for this program. And they definitely understood that and supported that. And there was an expert panel meeting that was held in 2013 to support looking at more of the global screening strategies in the U.S. Pacific Islands. So our next step is to introduce a demonstration project that show that it's feasible to do things like self-collection of HPV testing or VIA or primary HPV testing and improve coverage. So this is an example of how some of the things that we've learned globally has been able to be applied domestically. One of the challenges that CDC faces is that map that I showed you earlier. We are limited by congressional mandates for a domestic center like the Chronic Disease Center, which has the largest expertise of chronic disease experts, to only use our domestic funds for domestic work. So that is a limitation, and there should be strong consideration of at least allocating a proportion of our domestic budget for global work. And the other thing I wanted to mention is that a little actually goes a long way for global health compared to domestic health, and so there's some opportunities there. And as I mentioned, we actually learn a lot from working globally and can apply that domestically. Just briefly wanted to touch on capacity and talk about another activity or program that we've sort of farmed out globally. And this is the CDC EIS service, which is known for traditionally infectious disease work, and it's a 2-year postgraduate fellowship in applied epi. And the examples here are all chronic communicable disease, but there are non-communicable disease experts. But usually the people who are eligible are physicians, doctorate level scientists, as well as veterinarians and other healthcare professionals. And it's been in existence since 1951. And this is a map of the CDC or the EIS officers across the U.S. They work in state and territorial health departments, city and county and federal agencies, as well as the CDC headquarters. The field epidemiology training program was started first in 1980. It was the international one, first focused in Thailand, and it's established 65 programs, trained more than 3,100 graduates from 72 countries, with 80% working in their home countries, and many of them in leadership positions. So the capacity is eventually what happens is CDC is involved, and then there's country ownership, and then CDC is usually involved in only a peripheral fashion. So the structure is that there's trainees, there's a training model, and it's really on-the-job kind of training, competency-based. Only 25% exists in the classroom, and 75% is a field experience. And some programs are connected to schools of public health, or the ministries of health. And often the trainees are positioned to be working in the Ministry of Health after they complete their training. This is a map of the current program in green that shows the presence where there's a current CDC field epidemiology training program, and in blue where there's a field epidemiology training program, but there's a lower CDC presence. So for non-communicable diseases, this activity started in 2010, and over 300 FETP residents have been trained. There's been a curriculum that's developed on general chronic diseases, as well as each of these topic areas, including cancer. And then what's followed is a mini grant fieldwork with mentorship. and this has increased interest in non-communicable diseases. There are challenges, though, to introducing chronic diseases with the field epidemiology training program, is that there's not enough mentors on chronic diseases in country. So how do we supply that mentorship? Recruiting residents to focus on chronic diseases. And some FETPs are really interested in infectious disease rather than chronic diseases. Other restrictions that we found is that PEPFAR funding has been used to fund a lot of the FETP programs, but there's increasing number of restrictions for that. So, and also there's limited career opportunities once somebody goes in their Ministry of Health. Usually they tend to focus more on infectious diseases. So those are my comments and insights. Happy to take any questions.